So the subtypes of the umbrella term of atrial flutter is typical CTI-dependent atrial flutter. So typical CTI-dependent flutter is broken down into a further two categories. So there's typical counterclockwise atrial flutter, and this is because depolarization moves in a counterclockwise fashion. If you look at the tricuspid valve, it moves in this kind of direction. And then we have clockwise atrial flutter, which rotates around the tricuspid valve like this. Either way, the cavo-tricuspid isthmus is this region here, and both of these atrial flutters utilize the cavo-tricuspid isthmus region. So typical flutter usually refers to either counterclockwise flutter or clockwise CTI-dependent flutter. Both of them are CTI-dependent. Counterclockwise typical flutter is by far the most common type of atrial flutter, accounting for 90% of all typical flutters or CTI-dependent flutters. And clockwise atrial flutter accounts for about 10% of typical flutters. Together, these two are known as typical flutter. And they account for about 90% of all atrial flutter. So 90% of all atrial flutter is typical flutter. 90% of typical flutter is counterclockwise flutter, and 10% of typical flutter is clockwise flutter. Atypical flutter basically refers to all other flutters, and that could be upper loop re-entry flutter, could be lower loop re-entry flutter, could be biatrial flutter or mitral isthmus flutter. All of this doesn't really matter. Atypical flutter refers to not these two flutters, essentially, and is much less common, accounting for less than 10% of all atrial flutter. So typical flutter is a re-entry circuit that's confined entirely to the right atrium. It involves the cavo-tricuspid isthmus, which is this region here, which acts as the slow limb of the re-entry. And this limb of re-entry accounts for a third of the entire cycle length. So it accounts for a third of the re-entry time, the time it takes to rotate one revolution of the re-entrant circuit. It also involves the interatrial septum, the right atrial roof, and the lateral wall of the right atrium. And these regions combined account for 2/3 of the re-entry time. It's usually about 250 to 350 beats per minute. Rarely do I see it go above 300 beats per minute. In my experience, it's usually somewhere between 200 and 300 beats per minute. So quite fast. And this is what the anatomy looks like more clearly. So here we're looking at essentially an LAO view of the right atrium. So kind of looking straight in through the tricuspid valve of the right atrium, you can see one of the leaflets of the tricuspid valve here. And between the tricuspid valve and the IVC orifice is this kind of ridged region. And this is the kind of classical anatomical diagram of the cavo-tricuspid isthmus, which is this whole corridor between the tricuspid valve and the IVC. And you can see that anatomically speaking, it's quite disrupted. There's ridges and valleys and pectinate muscle continuing on from the crista terminalis region, and this can all disrupt conduction velocity and slow conduction velocity. And this is why it acts as the reentrant limb. Anatomical structures that are relevant are the eustachian valve and the eustachian ridge, which is the valve of the IVC to right atrial junction. We have the tricuspid valve leaflet, we have the crista terminalis terminating on the lateral aspect of the cavo-tricuspid isthmus, and then of course we have the coronary sinus with the Thebesian valve, the slow pathway in this kind of region here, and the AV node would be up here. So the goal here is to slowly step you into familiarity with the cavo-tricuspid isthmus region, so you can have all of these structures and its relevant anatomical boundaries in your mind during these procedures. Here we have the IVC orifice, here we have the tricuspid valve, and between the tricuspid valve and the IVC orifice, we have our cavo-tricuspid isthmus. You can see that the cavo-tricuspid isthmus is a ridged region, and this ridged region is a corridor of conduction between the electrically inert structure of the tricuspid valve and the electrically inert structure of the inferior vena cava. Anatomy can be quite variable here. You can see that there's a lot of ridges and valleys in this region, and those ridges are simply a continuation of the pectinate muscles, and this can make it challenging to ablate all these areas and in between these ridges. Another anatomical structure that we can see that's very relevant to CTI ablation is the eustachian valve or ridge, and sometimes this can be quite large and prominent, and it can make it really challenging to ablate regions of myocytes that are conducting through here, because you have to bring your catheter all the way like this and point it back like that, and that can be a little bit of a challenging maneuver. You can appreciate from the anatomy here that it's quite disrupted and that there's a lot of fiber disruption here, and this fiber disruption predisposes this region to anisotropic slowing of conduction velocities. This makes ablation challenging, and it makes this area predisposed to acting as the slow limb of a reentrant circuit, which is part of the reason why cavotricuspid isthmus dependent flutter is so common. Typical counterclockwise atrial flutter, which accounts for 90% of all typical flutter, which accounts for 90% of all flutter. So this is by far the most common type of atrial flutter you'll see on the ECG. And the ECG features of counterclockwise typical flutter is negative sawtooth flutter waves in the inferior leads, positive P waves in V1, and negative P waves or isoelectric in V6. And we'll go through why this looks like this. In the inferior leads, depolarization from the roof of the right atrium down the lateral wall towards the cavotricuspid isthmus region. This up to down depolarization moves with lead 2. So if you imagine lead 2 goes from the right arm to the left arm. So anything that moves with this vector will be positive. So depolarization cranial to caudal down the lateral wall results in an initial fast upstroke, and then depolarization through the CTI occurs perpendicularly to the lead 2 vector. So nothing happens on the ECG, so it results in a fairly isoelectric period. And then depolarization up the interatrial septum, depolarizing both the right atrium and the left atrium in an upwards direction, results in a sharp downward deflection. So that results in, this is why the flutter wave looks the way it does. This kind of rounded portion up the top where nothing is happening reflects the slow conduction through the cavotricuspid isthmus region. This sharp downward deflection refers to depolarization traveling up the interventricular septum, and this upward deflection refers to depolarization traveling down the right atrial wall. In typical anti-clockwise flutter, V1 is dominantly positive because the majority of the atrial muscle mass is depolarized upwards. So the interatrial septum is depolarized upwards, and so most of the, or at least half of the right atrium and most of the left atrium is depolarized caudal to cranial, so in an upwards fashion. And since V1 sits fairly high up in the chest, most depolarization moves up towards V1, resulting in a positive flutter